good evening to all of our worldwide audience. On behalf of my co-moderator, Dr. Sebastien Lustig from France, and myself, I'd like to welcome you to this third of a series of webinars presented to you by the Knee Subspecialty Committee of SICOT. And today's topic is about personalized knee alignment. And I'd like to start with Dr. Charles Rivière from Bordeaux, France, who will be talking to us about what are the downsides of mechanical alignment. Thank you, Dr. Rivière.
Thank you, Khalid. So I don't see my screen. Yeah, do you display my presentation?
No, you can screen share it on your side, unless it's not possible.
So I don't see the presentation. I just see the SICOT logo.
Can try to screen share, Charles, or it doesn't work?
Yeah, if you want, I can share my screen.
Please.
Yeah, of course. So can you see it, guys?
Yeah, it's coming. Thank you.
Good? Okay.
Perfect.
So the downside of mechanical alignment. So this is the evolution of the multiple surgical technique for implanting a TKA. So mechanical alignment, as we know, is the first ever developed technique for TKA. So the principle is simple. It's a systematic technique. We do the cut perpendicular to the mechanical axis of long bone, the femur and the tibia. And for the femoral rotation in the axial plane, there are two techniques. The medial resection, where we do 3-degree external rotation relative to the posterior condylar line, or we do a gap balancing technique, where we tension the ligaments, and this will define the rotation of the femur. So it's important to understand why MA technique was developed. First, it was when, 50 years ago, patient had severe arthritis, severe deformity, and clearly it was found to correct those deformity on a biomechanical point of view. Second, it was perceived as very difficult and probably impossible to restore the native anatomy of the knee, because there was a lot of bone loss and very severe arthritis, because treatment for arthritis were quite poor at that time. And as well, and it's very important to understand that before it was thought that the collateral ligament alone were not enough to stabilize a prosthetic knee. So that's why the first TKA were hinge, and this is a Shyam you can see on the right side with a hinge. And then after the hinge has disappeared, we understood that the collateral ligament were good enough to stabilize a prosthetic knee, but we removed the hinge, but we kept the MA cut. So first, let's be grateful, okay? MA technique is a good surgical technique, clearly. Most patients, 85%, are happy, okay? And this technique has enabled a widespread of TKA around the world. So clearly, we should be grateful to John Insall and Michael Freeman for what they've done, okay? Clearly. But there are still 15% of unhappy patients, okay? And the outcome of TKA are clearly inferior to the outcome of hip replacement. 50% of TKA patients have residual symptoms. 75%, they don't feel their knee as natural. It's not a forgotten joint. And despite high precision, because robotics or navigation, even when you perform MA TKA very precisely, it has not been a game changer, and unsatisfied patients remain. So clearly we can do better. So why? And clearly the answer is this one. It's because MA TKA is not physiological, okay? You can see on the left side the constitutional limb alignment with the constitutional varus. So when you do MA TKA, you align the knee and you try to balance as well the knee. So clearly it's not physiological. It is not what we call a kinematically aligned TKA. So MA, and we know that, we all learn MA together, when we were trainees. We've never been told, try to restore the knee anatomy. It has never been like this. It was do a perpendicular cut to the mechanical axis, do 3-degree external rotation to posterior condylar line. Okay, there is never any attempt to restore the native knee anatomy. And you can see the native knee anatomy is very unique. You know, we are unique from the outside. You know, we are as unique from the inside. The knee joint is unique for every patient. The conformity in the free planes and the laxity and the kinematics is very unique for everyone. So with AMA technique, just when looking at the frontal plane, the AMA replicates only 0.1% of human anatomy. So only 0.1% of patients, they've got a MPTA and an LDFA of 90 degrees, okay, only 0.1. So with AMA technique, there is a systematic alteration of knee anatomy, knee laxity, and knee kinematics. So it's not physiological. And this explains some of the disappointing outcome, altered joint perception, residual symptoms. Okay? So the consequence of this anatomical alteration. We know that the AMA technique, so it's not always easy to balance a knee. And more than that, we know that 30% of the patient, they cannot get a good knee balancing, even if you are Da Vinci, even if you are the best surgeon in the world, you cannot. And it's just, you know, it's just because of the anatomical conformation of the knee. When you do AMA cut, at the end of the day, you cannot balance it. If you balance the extension gap, you will unbalance the flexion gap. And there are some, you know, anatomy that clearly, you know, even if you're a fantastic surgeon, you cannot balance them. As well, when you do an AMA implantation, because we align the femoral component perpendicular to the mechanical axis, we know that most of the time, not for everyone, but for, you know, on average, the distal femoral epiphysis is slightly valgus orientated, okay, slightly valgus. So when you do an AMA implantation, you will add some material, you know, distally here, okay, so you will create a prosthetic overstuffing. So when you bend the knee, of course, you have the kneecap. So the patella is, you know, rotating around the femur with the retinaculum. And obviously, the retinaculum here will be stretched because of this overstuffing. Okay? So clearly, stretched retinaculum, the patella tilts, and it's a cause of pain, anterior knee pain. As well, when you do AMA technique, it's important to have the smallest implant, femoral implant possible. Okay, that's why we do the flush technique. Your anterior cut, when you size the femur, the femoral component, you need to have like an implant with a cut that is flush to the anterior cortex. So you need the smallest femoral implant as possible, because if you take bigger one, you will increase the overstuffing I was just talking on the previous slide. So, and obviously, when you do a flush anterior cut, you reduce significantly, most of the time, the offset of the trochlea. Okay, so you reduce the lever arm of the extensor mechanism. And obviously, if you reduce the lever arm, so you increase the joint reaction force on the kneecap, there is an overuse of the quadriceps, and it's a cause of anterior knee pain as well. Next, with AMA-TK, because of the alteration of the anatomy and the laxity, we do not restore a consistent medial pivot pattern. And we know that the medial pivot kinematic pattern is important because when you bend the knee, there is an internal rotation of the tibia on the femur. This reduces the Q angle. So this aligns the extensor mechanism. So it's good for the patellar tracking. Okay. So if you don't have a consistent good medial pivot pattern when you bend the knee, and then it causes, you know, increased stress on the kneecap. Okay, and then the anterior knee pain again. So you can see there are 3 good reasons why the patellofemoral joint biomechanics is quite poor with the AMA-TKA. And that's probably explained why there are so many anterior knee pain after the AMA-TKA. And if you add the difficulty to balance AMA-TKA, then you probably understand why AMA-TKA doesn't feel that right. So when you compare AMA and KTK, on average, there are many papers now that have been released. There are 15 points difference regarding the foregut joint score. So AMA-TK doesn't feel as well as a KTK, probably because of this anatomical alteration, but not just anatomical and kinematic alteration of the native knee. Another thing, another consequence from this alteration of the anatomy is the knee adduction moment. And it's very interesting because AMA technique was developed to improve the biomechanics of the knee. And what we've learned is that, in fact, if you keep, the constitutional anatomy, okay, unless it is aberrant, but when it's not aberrant, it's like if you restore the knee anatomy, the knee biomechanics is improved, is better, okay? The knee adduction moment is lower when you keep some constitutional varus versus if you straighten the leg by doing a MATK, okay? So what I want you to remember is that the AMA technique is non-physiological, okay? Clearly it's not, and it has been developed like this, okay? So there is no need to evidence to justify this, it's just the way it has been developed, okay? And physiological damages, now we understand that they are clinically deleterious, okay? Not every time, because 85% of MATK patients are happy. But clearly, if the alteration is important, maybe the outcome will be poorer, okay? The modern personalized arthroplasty clearly is more physiological, and you've heard about that. It's kinematic alignment, functional alignment, and all my core speakers today will talk about that, and clearly it's our future. And interestingly, 50 years after the launch of MATK, if you look at the pillar, the rationale for developing an MA technique, today, 50 years later, none of them are valid, okay? Keeping the collateral ligament is fine to get a stable knee. We can restore a native knee anatomy, clearly. We do that every time with kinematic alignment and functional alignment. We know that most patients who are developing osteoarthritis, knee osteoarthritis, they don't have an extreme or an aberrant native anatomy. Most of them, they've got kind of a normal, subnormal anatomy, okay? And we know that if you keep some the native knee anatomy, the biomechanics of the prosthetic knee will be better. Most of the time, of course, unless there is an extreme and aberrant constitutional anatomy. So I have finished, and I thank you for your attention, and the next speaker now. Thanks.
Thank you very much, Dr. Rivière. And next is my co-moderator, Dr. Sebastien Lustig from Lyon, France, who will be talking to us about the concept of various personalized alignment for total knee replacement.
Yeah, thank you, Mojieb. So I will try now to present the different options when we talk about how can we personalize the way we do surgery. We are gonna deep dive into the individualized medicine world, and actually it makes a lot of sense because from Charles just presented you, we understand that with the huge variability that we all have regarding diverse alignments, makes sense to think about something more personalized. So it's true for coronal alignment. It's also true for sagittal and rotational alignment. So it's a real three-dimensional issue, and it's not only about the bone, it's also about the ligaments. There is huge variability considering ligaments in extension, but also in flexion. You can see with gaps between medial and lateral up to 7 millimeter. And that's also without forgetting the third compartment, which is very important, which is the anterior compartment. So when we talk about personalized alignment, it's alignments for the bone, ligaments, and patellofemoral, joints. Charles just mentioned it. Today, where we are, it's not perfect by far. We still have some patients who are dissatisfied. And when we look, at what we've been doing for decades, which is a very systematic approach, actually it makes sense because this is some of our personal experience, 1,000 knees. We went for mechanical alignment and using the CPAC classification, you see how we change most all of them to neutral, joint line. And we know from, outcome studies that maintaining and restoring the joint line makes sense if we want to achieve better outcome. So this is something to consider when we're going to look at the different options for personalized alignment technique. Today, there is a paradigm shift. That's why we are so many of us interested in this world of personalization of how we can do, alignment. We published this paper together with Sebastien Parratte and the team in Lyon, Cécile Bataillé, trying to summarize this. And To make a long story short, I think we can consider probably 4 different categories of personalized alignment technique, and I will go one by one. The first one, of course, and a lot of credit to Stephen Howell with the kinematic alignment technique described with only a caliper to measure the cut, to pure surfacing of the knee. So for Stephen and all the surgeons following his philosophy, they want to maintain exactly the bony anatomy, especially the femur has to be exactly similar. You really restore the pre-arthritic anatomy on the femur, and you just measure the resection. You try to restore all the different kinematic axis, and if there is something to adjust, it's based on the tibia. So kinematic alignment, you maintain the femur, and if you have something to do, you play with the tibial cut. Very important to understand that. Many papers published, short-term outcomes are at least equivalent to mechanical alignment, so it's not detrimental. We now have 10 years data. But why you have other options to consider? Number one, because when you look at the residual varus, we know that you increase the load, and a lot of surgeons are afraid of maintaining too much varus, especially in the tibia, and the potential consequences. And also, just Charles mentioned, you have normal anatomy, but you also have aberrant anatomy, and it's important to be able to address that. And it's not only true for coronal alignment; it's also true for patellofemoral joint and for rotational alignment. And that's why with the PUK technique, many papers show that you have patellofemoral issue potentially for this aberrant anatomy. And it can be up to 10% of the patient when you need to adapt the rotation. And if you follow strictly the guidelines, you might end up with some internal rotation of the trochlea. So that's why, because of the new tools, and remember, Stephen Howell has been using only a caliper. He didn't, he has not the fancy tools available at that time. And because of this fancy tool, you have different options. You have the restricted kinematic from Pascal-Andre Vendittoli, because he was worried about this potential issue with aberrant anatomy. So he offered some boundaries, and you have to follow these boundaries to maintain the +-3 overall, coronal alignment. You have the inverse kinematic from Philippe Vinocq de Grave, when you maintain the tibial anatomy and you play with the femur, and then you adjust, with the femur and with the technology. And he's using robotic or navigation for that. And then you have the functional alignment. Functional alignment, David is going to talk about in details about that. But to make, again, a long story short, it considers the 3 dimension, bone, gaps, but also anterior anatomy. And this is with a very step-by-step approach. It's very well described, and you will see here David showing you the technique, but basically you think 3D and you try to play with the cuts, not only in coronal, but also in sagittal and in horizontal plane, to try to restore not only the bony anatomy, but also considering the gaps. And that's one of the main difference with kinematic alignment, which is maintaining the physiological imbalance regarding gaps. And for functional alignment, you try to address that and to keep some kind of a safe zone regarding gaps. That's also true for the patella tracking. And with functional alignment, you can also restore the anterior offset. And that's also a difference with the other personalized alignment technique. So this is the case. So how do you address this? Do you go systematic like this? This is probably what all of us we've been doing when we were trainees and at the beginning of our career. And now, with more personalized, we try to maintain the joint line obliquity, just like here. And you can see these numbers as different from the guidelines from, mechanical alignment philosophy, but you stay in a safe zone and you can maintain some of the native anatomy. So the take home, I think we agree, we need the personalized alignment philosophy. You have different options: kinematic, restricted, inverse, restrict, functional, and all of them, I think are also, very aware of the idea that if we go into this direction, safety is very important, and we need to understand what are the safe zones. That's going to be the point of the next speakers to show you that with the different techniques. Thank you very much.
Thank you, Professor Lustig. Our next speaker is Dr. Khalid Alishkeikh from Riyadh, Saudi Arabia. He'll be talking to us about the principles and surgical technique for calipered kinematic alignment. Khalid.
Thank you, Mojieb. Do you hear me and can you see my screen?
Yes, we can, and we can hear you.
Okay, so off we go. So I'm going to talk about principles and surgical techniques of caliper-verified kinematic alignment. We're going to talk about the definition, principle, surgical technique of caliper-verified kinematic alignment, and a short look at the outcomes. So this is an article that Charles have shared in his talk. It's an important article. It looked at 4,800 CT scans of patients undergoing total knee using a PSI. And the variation in their knees was humongous, was huge. And on the MPTA side, it went from 20 degrees of varus to 20 degrees of valgus. On the LDFA side, it went from 15 degrees of valgus to 11 degrees of varus. So I would like to reiterate what Charles has nicely said. We are truly different from the outside as we are from the inside. Freeman has identified multiple axes in the knee. Two of them were flexion extension axes, and one of them is of the tibia, upon which it flexes and extends on the femur. The second one is of the patella, upon which it flexes and extends on the femur. And the last one was the internal external rotation axis, and it's located in the middle of the medial tibial plateau. So kinematic alignment co-aligns the axes of the joint line of the components with the three kinematic axes and joint lines of the prearthritic or native knee, without ligament releases and without placing restrictions on the preoperative deformity and postoperative correction. So we basically resurfaced the femur, accounting for lost cartilage and saw curve, maintaining joint line obliquity. We co-align the axes of the component to the axes of the prearthritic knee and restore resting lengths of the ligaments. You need really to know the design of your implant and the thicknesses of especially the distal and posterior femoral condyles. The flexion and extension, as Seb has mentioned, are balanced through the tibial cut. So again, I would like to reiterate a few important points that has been mentioned. Kinematic alignment gives a low adduction moment, peak adduction moment, and lever arm, which lowers the risk of a varus tibial loosening despite placement in varus. So this is a patient who had an MA TKA on her left side and came over to have a total knee on the right side, and kinematic alignment has been performed. What I would like to draw your attention, this is the center of mass to center of the ankle lines, and there you go. You see that if you draw a line from the middle of the knee to that center of mass line, then you see that it's a shorter line on the kinematic alignment side on the right side of the patient. If you also have a look on the joint line obliquity on the same patient, the natural joint line obliquity, as you can see, is pointing downwards. On the MA, you kind of really change that joint line obliquity. And when you perform kinematic alignment, you notice that the joint line is going to the same pre-operative way. And you also can realize that it's more parallel to the ground. So our target on the femur is cutting an equal thickness of the distal and posterior femur to that of the femoral component. We always compensate for lost cartilage and saw curve. Lost cartilage is about 2 millimeters and the saw curve is about 1 millimeter. So we start with removing the ossified, scraping any cartilage left on the worn side. And this is a very important step where you open the femur to place your guide. Please make sure that it's about 5 to 10 millimeters off the upper part of the femoral notch. And this is basically trying to avoid placing your femoral component in flexion if your opening hole is less than 5 millimeters from the upper part of the notch. It would look somewhere like this in the operating room. Then we use the 2 millimeter offset distal femur referencing guide. It has an offset on the worn side, which is about 2 millimeters. And we place the distal cutting guide and perform our cuts, verify with a caliper, and always record the thickness of the distal cuts. You can always, if you have a less thickness in your cut, you can always go back and recut. And then you place your posterior referencing guide at 0, so no external rotation, size your femur, and then place your 4-in-1 cutting block. We start always with the posterior cuts, so if we need any adjustment, we can do that before doing the rest of the cuts, and always record the thickness of your cuts. This is a verification check sheet used by Dr. Howell, and it has the distal femoral resection and the posterior femoral resection, including a recut if you had to do it. The important thing is that what you cut should equal the thickness of the implant. Going all the way to the tibia, we set the tibial component coincident to the native tibial joint line. And first, upon exposure, you'll expose the tibial plateaus. You'll draw an ellipse or a circle on the lateral tibial plateau and bisect it, as you can see in the picture. And then you draw a line perpendicular to that line between the tibial spine, and that would set your internal-external rotation of the tibial cutting guide. Apply the tibial cutting guide and tower, adjust for varus valgus. Usually we start with moving the rod to 12.5 millimeters laterally, and that will get your jig at 2 to 3 degrees of varus to start. And then we adjust proximal distal using the stylus and adjust the slope after that. When you're done with these steps, then you fix your tibial cutting jig after adjusting for internal and external rotation. I would just like to draw your attention on the slope part. Please pay attention when cutting the slope. You should replicate the patient's slope or slightly less if you're resecting your PCL. Please make sure that you do not cut a slope more than the patient's natural slope, because that has been shown to be a cause of failure with wear on the poly side. Record your cuts. The verification check should be at the base of the tibial spine where you still have some cartilage. And then check your gaps. The extension gap should be rectangular and should be a snug fit. The flexion gap at 90 degrees should be tighter on the medial side, a bit looser on the lateral side, about 2 to 3 millimeters, just like the normal knee. You also could check the offset, both upon exposure and then after putting in the trial. If you follow what we have mentioned, then if you place this on the medial side of the patellar tendon, then you should have a reading that is 2 millimeters less than the initial reading, because you've made up for 2 millimeters of cartilage. Now, when you have it much more less, then you should think about cutting more slope. When you have it a bit bigger, then you should get a bigger poly in and recheck or decrease that slope a bit. Always have a decision tree for you. I won't go through it, but I would like to draw your attention that it's always either removal of osteophytes or adjusting your tibial cut, as Seb has mentioned. In terms of outcome, there are 13 out of 15 randomized controlled trials from all over the world, all showing that KA was better than MA in terms of outcome. The longest follow-up study was just published by Dr. Howell. It was a 16-year follow-up and shows 93% survivorship, and that's still better than the 85% survivorship of MATKA published by Parratte in JBJS 2010. In summary, caliper verified technique is easy, accurate, and reproducible. Always use a verification sheet, record the thicknesses, follow a decision tree, avoid placing your femoral component in flexion and your tibial component in excessive posterior slope. And that is to avoid anterior knee pain on the femoral component side and posterior polywear on the excessive slope tibial side. Thank you.
Thank you very much, Khalid. Very comprehensive description of kinematic alignment. Now, David is going to talk about another option, which is, functional alignment technique. David.
Thanks very much, Sebastien. Sorry.
Perfect.
Okay, perfect. Thank you very much, Sebastien, and thank you for the invitation to speak today. There's just my disclosures. So, as we've heard this morning, most of us would be very comfortable now with the concept of alternative alignment for our patients. My favorite philosophy currently is functional alignment, as Sebastien has explained, and I'll go through the reasons of why I believe this and why and how I do it. So the reason I don't go pure kinematic or I go functional alignment is because whilst I see the value in bone phenotyping and particularly the joint line obliquity, in my experience, what I found was that the bony phenotype doesn't tell the whole story. And what we found was that in our cohort of patients, what we commonly observed was that the bone phenotype alone, as I say, only had a moderate correlation with a patient's varus valgus laxative their knee. So that same patients could have a similar bone anatomy, but very different ligament behavior. And that's highlighted in these two cases here. So this patient here has an arithmetic HKA of 3.2, but when we distract their ligaments, it corrects about 2.1 degrees of varus. Another patient with a very similar or same morphotype, same CPAC classification, however, when we stress their ligaments, now corrects to almost neutral. So in my mind, these patients have very different soft tissue characteristics, very individualized soft tissue characteristics, and therefore are quite different needs to balance surgically. And so I guess my philosophy is more about balancing the gaps rather than leaving a patient with residual constitutional laxity, and thus my preference of functional alignment. And so what we found was that when we considered both the bony anatomy and the individualized soft tissue characteristics, we found that when we considered both those factors, that about a third of our patients had up to 3 or at least 3 degrees difference in the alignment of their components than from a pure kinematic alignment. So as Sebastien has already explained, what is functional alignment? Functional alignment is trying to reconstitute a patient's 3D constitutional bony anatomy, but taking into account also variability of individual soft tissue laxity. And I think it's also important to remember that prosthesis geometry also plays a role, because different prosthetic designs have different shapes. And what you're trying to do is create harmony between each of these three variables. And the other important things to consider is that it's a three-dimensional reconstruction. So it's not just in the frontal plane, but also the sagittal and rotational plane, which includes your patellofemoral joint. And I think it also is important to remember that it's through the whole arc of motion, not just the extension, not just the flexion, but we're trying to balance it through the whole flexion arc. And I think robotics has certainly transformed our ability to achieve this. Robotics gives us information on all of the variables that we're trying to control, gives us objective numerical data that we can play with. It allows us to pre-plan, but I think one of the big benefits also for me is the ability to measure what I've actually done, record what I've actually done, and hopefully be able to use that data in the future correlated with my patient outcomes as to whether what I did was correct or not correct. Maybe I'll be shown in 5 years to be a fraud. For what it's worth, the other important thing about functional alignment is it is bounded. I have boundaries to what I will resect. I have certain boundaries to the intercompartmental gap differences that I accept. There is probably not a lot of evidence for what I've chosen here, except that I think I'm not far off experts in the literature, such as Sebastien Lustig, I think go for similar parameters. I think one of the big things that we still have to decipher is how much force we apply when we are stressing the ligaments. So this is my surgical technique, which I'll run through. And it is a tibia first technique, and I'll explain why I do that first. So my initial exposure is medial parapatellar, obviously insert your robotic pins. I then try to remove all the accessible osteophytes that I can see, remove your ACL. I do a posterior stabilized prosthesis, so I remove my PCL as well. And then what I do is that I'll turn the volume off, is that I try to stress the ligaments through the range of motion. And now this is just a manual stressing of the knee. The medial collateral is quite taut, so I don't think you can overstress it. I guess the skill is trying to stress the lateral ligament, which is often not easy in flexion and is a little bit objective or an art rather than a science just yet. Once I've stressed my ligaments, then I have my gaps and my alignment, and then I pre-plan. And what I'm aiming for is balanced flexion extension gaps within 2 millimeters, as I say. I try to have a slightly looser flexion gap than extension gap. So I start at the bottom left-hand corner, which is my tibial coronal alignment. I then choose my tibial depth, my posterior slope. Once I've satisfied with these, I then finish my extension gap with the coronal alignment of my femur plus its depth. And when I'm happy with the extension gap, I then turn to the flexion gap and the patellofemoral joint, which I can alter with my femoral component rotation, my femoral component size, as well as the AP position and the flexion extension of the femur. So you can see it really is a three-dimensional planning of your component position to the bony anatomy and the gap differences. I then perform my tibial cut and check that my tibial cut is correct, or at least within what I had planned to do. Otherwise, I will go back and recut. And the reason I do my tibial cut first is that what we found is that cutting the tibia alone actually changes the gaps to a not insignificant degree in quite a number of patients. But the really pertinent or important point is that it actually increases the flexion gap more than the extension gap. So you can see here our flexion gaps changed by, on average, a little over 2 millimeters, where our extension gap really didn't change too much at all. So what's really important to note is that not only is the magnitude of the flexion gap change bigger, but there's a wider spread. So it's a bit more variable across different patients. So by doing the tibial cut first, it allows me a second chance of fine-tuning my femoral component position to achieve the balance I'm looking for before I commit to my femoral cuts. The other reason I like to do the tibial cut first is it allows me a chance to remove the previously inaccessible posterior osteophytes to clear the posterior recess, again, so that I can fine-tune my balance and hopefully have a fully balanced knee that I was aiming for. And so once I've done this, I've done my tibial cut, cleared my posterior axis, I then perform a second stressing of the knee, use this spring-loaded tensioner, which I then reduce the patella. And you can see my knee has slightly bigger gaps now. I've increased my flexion gap by 1 millimeter or 1.5 millimeters, and the knee is now actually slightly hyperextending. So by doing this second step, I get a second bite at the cherry at balancing my gaps. This was my initial planning screen, and now this is my subsequent planning screen after the tibial cut. And you can see I have made slight alterations, only very minor ones, but it makes, I guess, the second bite of the cherry makes me feel that I'm getting a more balanced knee than perhaps I could if I did all the cuts initially. And as I say, I stress again, the problem was that what I found was the flexion gap increases more than the extension gap in a lot of the cases, and this can't be fixed alone by just an insert increase. Once I've finished all my cuts, I do a final balancing. Sorry, I'll turn the volume off. Hopefully the gaps are relatively balanced now, but the reason I do this is it gives me one final chance if I want to change my poly insert size. So in conclusion, why do I do a functional alignment technique? Because it's an individualized approach aiming for harmony between constitutional bony anatomy, individual patient soft tissue characteristics, but also the implant design that you choose. As it's three-dimensional, all three compartments are included. Robotics enhance your ability to plan and execute such a philosophy, but also importantly, it helps us record exactly what we've done so that we can learn from it. And what we still don't know yet is what are the alignment boundaries and what are our gap balance targets. Thanks very much.
Thank you very much, David. And that's a perfect transition to our next speaker, Pascal-Andre Vendittoli, who is going to talk about potential limits when we talk about how can we personalize surgery.
Thank you to the organizers and the SICOT for inviting me to this webinar. I'm Pascal-Andre Vendittoli, co-founder of the Personalized Arthroplasty Society with Charles Rivière and a true believer in patient-specific and ERAS surgery. As it was presented by Charles, it is now the end of a one-size-fits-all technique. We need to abandon the MA dogmas to improve our patients' function and satisfaction. In 2011, Stephen Howell convinced me right away that resurfacing of the knee joint was the solution to improve my patient outcomes. His K is a true revolution for knee replacement surgery. So why did I propose the restricted kinematic alignment? In this paradigm change from a systematic to a personalized surgery, before reproducing all anatomies, two main questions need to be answered. First, what is a normal lower limb anatomy? Second, what anatomical parameters are compatible with the current implant material and fixation methods? We've been thinking about this for a long time, and we are far behind in orthopedic surgery. I found this paper published in The Lancet in 1947. How can we define what is normal? First, we can look at the statistical distribution of the values. Secondly, we can only consider value to be abnormal when they are linked to a disease process or a dysfunction. Let's start by looking at the statistics. Hirschman and colleagues analyzed 11,000 lower limb CT scans of patients with knee OA and patients without OA. As you can see in this graph, the two populations have near normal data distribution, but with different means. In a normal distribution curve, we could define normality as ±2 standard deviation from the mean, abnormality more than 2 standard deviations, and deviance or aberrance above 3 standard deviations. But being away from the mean, is it linked to a problem? In the human diversity, we see individuals with very extreme characteristics, but without any pathology. A more valuable way of classifying the normal from the abnormal values would be to use a cutoff linked to an increased odds of a disease or adverse event. Let's take the blood pressure example. It is well known that high blood pressure above 160 of systolic is linked to an increased risk of stroke, heart disease, kidney disease, or visual problem. Similarly, for the hip, we know that some parameters like the Weiberg angle of less than 20 degrees will lead to joint degeneration. Please look at these radiographs. How rapidly this dysplasia hip progressed to a severe OA. Neck remodeling is also very impressive in only 3 years. Surprisingly, on the knee side, there is a very important void of science and data. Very little is known regarding the link between anatomical parameters and future joint degeneration. After more than 50 years of joint replacement research, we still do not know what is a normal and what is an abnormal knee joint. We still do not know if we should replicate all knee anatomies. Secondly, a TK implant is not a natural knee. We do not know if the actual implant materials and fixation methods are compatible with all anatomical parameters to provide a long-term implant survivorship. That is why we should question ourselves. Should all patient anatomy be reproduced when performing a TKA? As we know that polywear increases with cup abduction in hips, we would never replicate the acetabular dysplasia with our implants. I believe it is the same for the knee. So the question is not should we have boundaries? The real question is what should be the boundaries? In 2011, I proposed a restricted alignment protocol. I would like to review the 5 principles of its fundamentals with you. I propose these principles based on patient anatomy description. The first principle is the HK boundary of ±3 degrees. This number was selected based on 2 factors. First, to include more than 2/3 of the patient without any modification. Secondly, these numbers were not associated with the decreased implant survivorship in MATK history. If we look at the patient anatomy more in details, we observe that the mean distal femoral angle and the mean proximal tibial angle are approximately 3 degrees. There were also around 20% of the patient with anatomy above 5 degrees. As a second RK principle, I suggested to limit the tibia and femur joint orientation to 5 degrees. This limit corresponds to the mean value ±2 degrees, as you can see on this graph. We looked at the bone anatomy, but soft tissue and ligaments are also very important. Most anatomical studies agree that the collateral ligament tension is subjected to individual variability, but in general, female are looser. MCL is tighter than LCL, and both collaterals are tighter in extension than in flexion. The key point is that in a native knee, collateral ligaments are not isometric. So restoring normal ligament laxities will favor joint kinematics and correlate in clinical study with higher patient satisfaction and better clinical score on short-term follow-up. Thank to Indeli's group for publishing this great paper. So our third RK principle is to restore native knee collateral balance in laxities versus aiming for ligament isometry. We should avoid all gap balancing related technique to modify bone resections. Next question to answer. When anatomy adjustments are required, where should it be performed? On the tibia, the femur, or both bones? We know that the key of the knee joint kinematics is the femoral anatomy. Maintaining its flexion axis orientation and joint surfaces anatomy is a priority for RKA. This is our fourth principle. When performing anatomical modification to reach our RK thresholds, we should favor femoral anatomy preservation. The fifth and last RK principle is to resurface the intact compartment. It would be the lateral compartment for a varus knee as example. Doing so, I'm sure to preserve the joint line level and will be in a familiar situation if I need to perform ligamentous release on the disease compartment. To simplify the decision-making, here is the RK alignment algorithm to follow for each patient. This algorithm follows our RK principle and favor patient phenotype preservation, as adjustment will be performed on the most contributing bone to the deformity. Beyond determining boundaries, I can affirm that in clinical practice, we are facing complex cases which need specific considerations when trying to perform a personalized surgery. With my colleague Charles Rivière, we tried to summarize in a personalized arthroplasty classification these cases in an effort review publication. Even if the restricted protocol includes the vast anatomical variations, it was not designed to take in account specific situations like acquired extra-articular deformities. Another pathologic situation occurs when the peri-articular soft tissue has been severely modified by the disease process. Severe windswept deformity, like this one, require a constrained implant on the right knee and a hinge on the left. We are far away from a KA technique. And last, aberration of the human being are unrelated to their particular bone anatomy. With the same skeleton, you can face different limb morphologies. You all encounter patients with valgus alignment and associate very large lower limbs. These patients are not very happy if you keep their knocking knees. Knee resurfacing for these cases will maintain a thigh friction and may be unsatisfactory to the patient. I proposed in 2011 the restricted K alignment protocol and published different papers reporting the clinical results with cemented and uncemented implant. But the most important result is the patient satisfaction. With 95% of the patients satisfied, we are way above 80% reported with MA. In another study, we obtained a mean forgotten joint score of 77, which is much higher than the result obtained with MA-TKA, where most studies report a mean of 55 to 65. So what is the personalized arthroplasty? It is still an evolving concept. In my point of view, there are four main pillars. First, we should meet patient expectation. Second, we should offer a patient-specific perioperative care, minimizing adverse event and optimizing recovery. Third, it is the quest for the forgotten joint, which involves anatomy and function restoration, accurate surgical technique, and improved implant design. Last, we want to offer a lifelong implant survivorship to our patients. I believe that RK is the ideal compromise to achieve these goals while avoiding reproducing pathological anatomies and keeping the lower limb alignment in a safe range compatible with implant long-term survivorship. Keep in mind that boundaries will certainly evolve over time, but I'm sure that restriction will persist. Please be part of our second PASS meeting in Chicago. It will be a fantastic event to share further ideas and break dogma. Thank you very much.
Thank you, Dr. Vendittoli. Now, we keep the best for the last talk. So Seb Parratte is going to tell us what's ideal if we go for personalized and what's the worst candidate. Seb.
Thank you very much, Seb. Can you see my screen, guys?
Yeah, we can.
Yeah.
Thank you so much for that. And we saw a very nice talk today. And the idea is to see if there's an ideal candidate or a worst candidate. And you see this patient, I would like to ask you, what would you propose? Restricted, inverse, functional, kinematic, or personalized alignment? This point is to say that sometimes we have to think a little bit further. There's, to me, no ideal or worst candidate. I do think that every patient deserves a personalized alignment in a way or another. However, in our daily practice, there's 10 situations where you have to do personalized alignment, and you have to be ready for sometimes some challenges, and you have to be able to identify that ahead of the surgery. To me, the first point that might limit the capacity to do a proper or standard personalized alignment is the ligament deficiency. You have to recognize the insufficiency of the MCL preoperatively because it might increase constraint, and then you have to be ready intraoperatively to use a specific type of implant. The second situation is the constitutional extra-articular deformities. We published with Cécile Bataillé and Mojieb Lustig a paper showing the influence of the extra-articular deformity into the joint. You have to be able to identify that preoperatively to understand the impact of the extra-articular deformity on the joint. And this is coming from an old, most of the time forgotten classic paper analyzing the influence of the deformity based on the distance of this deformity to the joint. So you have to look at your preoperative X-rays because the same angular deformity at a different level based on the joint distance will have a different impact, and you have to analyze that preoperatively to be able to know what would be the consequences on your implant. So for example, on the left here, there's absolutely no extra-articular deformity. You will be able to resurface the joint intraoperatively without any difficulty. And if you take the case on the middle, you will know that you will have some residual deformity at the end of the surgery. And as Pascal-Andre Vendittoli showed before, you have to see if you will still be within the boundaries or not. So this is something that you have to look at. The other case, which is most obvious but not more easier, is the post-traumatic extra-articular deformities. There's different consequences on the joint based on, once again, the importance of the angular deformity, and second, the distance to the joint. There's a classic paper written by Arun Mulaji, and please have a look at this paper. You will learn a lot on extra-articular deformities. You have to treat the problem. And Seb showed us a beautiful case of an osteotomy where he actually maintained the deformity, but sometimes you have to correct the deformity before going to your standard normal arthroplasty. You also have to have a look at the post-traumatic intra-articular deformities, because here there's a bone loss, there's a deficiency and the segmental deficiency, and it's the same principle as in the revision case. If you have to have an optimal stability, you will have to compensate for the segmental defect and rebuild, not only fill, not only adapt the cut, but also rebuild the segment that is gone due to the trauma. You have to be very careful with post-osteotomies. We always look at the frontal plane for post-osteotomies cases, which is not the only one. And you see that sometimes there's an excess of slope that you do have to compensate. And computer-assisted surgery, whether it's robotic or any type of other form, is very helpful to help you to do that. I'm very careful as well with the fixed valgus deformities. It still does require releases, sometimes an increased constraint, and sometimes for this type of case, a personalized alignment will be a hinge, and it's still a type of personalized alignment, but you have to be ready, have the implant ready in your OR to do the case. You have to be careful with the fixed flexion contractors as well. We do have a lot of patients in the Middle East with fixed flexion contractor, segmental defect in the middle aspect of the knee. You have to work on the osteophyte. You have to work on the capsule. You sometimes have to do a vertical facetectomy of the medial tibial plateau to be able to restore the full extension and to restore and correct the fixed deformity in varus. You have to be careful as well to the preoperative patellar maltracking. Indeed, if you do apply the basic principle for a patient with already preoperative maltracking and do a standard rotation to the PCA, you might have some problem for the patellar tracking, and you have to be aware of that. Look at your patella preoperatively on your merchant views or on your CT scan, and you have to be able to adapt the rotation as well. As Pascal-Andre Vendittoli showed, it's not only about the bone. You have to be very careful about the super obese patient, because the rules of a classic standard personalized alignment, whatever technique you choose, are very different. And you have to increase the fixation. You have to be very careful about the tight contact, because it might induce some forces that you were not expected. And you have to use stem and different constraints sometimes. And these patients are very difficult to take care of. Be careful of the super osteoporotic patient as well. In the Middle East, there's a lot of very osteoporotic patient. Be careful of the implant that you use, no box, no hammering, and be very careful with the excess of valgus on the femur as well for this patient, because you might end up with a fracture. So to summarize, to me, every patient deserves a personalized alignment in a way or another. Just please be aware of these 10 situations where you have to do a personalized alignment and be able to identify this situation preoperatively, to be ready intraoperatively, and have the tools that are going to help you to do well for this patient. Thank you very much for your attention.
Thank you very much, Seb, to show us that of course there are some cases where we have to consider maybe different options, and this makes a lot of sense. And also depending on where you are in your practice, because you are dealing with some very severe anatomy together with Mojieb, Khalid, and in Europe or with Charles, and in Australia with David, we have different patients, so we need to consider that. Mojieb, maybe because we are just on time, you want to give some final words of wisdom?
I think there's a question. Oh, no questions from the audience yet. So we were hoping to get any questions. But one of the cases that Seb showed, in the beginning, it's extreme varus when you have this collateral laxity, and these are very common in Asian continent, just because people wait a long time before they come for surgery, and they have a huge degree of deformity. And the question to the audience is, the very extreme deformed anatomy, are these patients amenable for non-mechanical alignment? Let's put it that way, or the personalized alignment.
Charles, you start. Charles, David, Khalid, and Seb.
Okay. I'll give it a go. So clearly, if the soft tissue envelope, is not functional, so then you need something more constrained. Okay. So in order to do a kinematically aligned total knee, you need to have good soft tissue envelope, a good collateral ligaments. Regarding the deformity, so let's not talk about the osteoarthritic deformity, the one because you have a loss of cartilage and bone, and you got a subluxation between the femur and the tibia in the frontal plane. We don't mind about that. What we only care about is the constitutional deformity. Okay, so if you have a patient in your clinic, it's 20-degree varus, but after surgery, after doing the cut, removing the osteophyte, is like 2 or 3 degree varus, of course, you go for a kinematic aligned total knee. Okay? So as Pascal Vendittoli said very well, so the question is not, are there boundaries, to align our implant? Of course they are. The question is, what are the numbers? What are the figures? Okay? And so clearly, it is there are aberrant anatomy that we should not reproduce, and we should attenuate the deformity, and we don't know the number. I personally reduce my extreme valgus, constitutional valgus. I don't let a patient with post-op, 7-8 degree constitutional valgus. I don't do that. They got knocking knee, it's ugly, and that. I mean, it's functional, but it's not. It's not aesthetic, and it's not. So I undercut my lateral tibial plateau by 3-4 millimeter. So from 8 degree constitutional valgus, I bring the patient to 4. Okay.
Yeah, we promise we will not let Stephen Howell know. Charles, you said that. Just between you and I. David, is it easier for you with a functional approach to deal with this kind of patients? You think it's
Look, I like Sebastien's concept. Everyone gets a personalized alignment. Is it easier with functional alignment? No, because it depends on your boundaries. So someone with such a deformity, it's about compromise, right? So if I can't cut the bone and balance the ligaments, if I have to cut too much bone, then I'll do a release. So my compromise has been on the release side, and I have to increase my constraints. So it's about achieving what I say. Someone told me it's the harmony between your soft tissues, your bone, and your implant design. And if it means increasing your constraint of implant design, increase constraint. It means releasing your ligaments, release your ligaments. But it's about considering all those factors together and coming up with the best compromise for that patient. Now, I agree that boundaries are probably still a little bit unclear, but someone with such a deformity, no, I would release, correct, and constrain as needed.
Khalid, your approach with if you consider KA, I'm sure you have many of these patients. Do you go for a different approach in this case?
So for our patients, the majority would fall into the kinematic alignment, restricted kinematic alignment protocols without any problem, because the majority are varus knees. But I do agree with Charles' concepts regarding valgus knees. Those I do decrease their valgus, their extreme valgus, yet keep them in valgus at 3-4 degrees, up to 5 degrees, I don't mind. But in terms of the varus knees, when you have those tibial bone loss, I try to compensate with my tibial cut. I try to go lower millimeter by millimeter until I get sufficient bone surface and go slightly up on the poly. I don't really go too much, maybe 2-3 millimeters, increase the poly size, and usually they're okay. I do pay particular attention to the collateral tension while I'm doing so. So these cases kind of take trial and error on my side, keeping my boundaries the same, but eventually they do okay. A very important question, a very important point that Seb has mentioned. In our population, I don't get into the OR until I make sure that my osteoporotic patient has been on treatment, seen by endocrinology. These kind of things are extremely important. Choosing when to go is also important in these big deformities that we do have.
Yeah, global approach. And Seb, you mentioned many different cases. You talked briefly about implant. Do you change also the implant or the fixation depending on the situation, especially with the bone quality you guys are facing?
Yes, Seb, I do increase the fixation, and I'm not afraid to increase the fixation. And that's why I don't want to be dogmatic the other way around. We have been dogmatic with mechanical alignment for many years. The idea is for personalized alignment to not be too dogmatic the other way around. So if I do need to use a short stubby stem, I'm going to be very careful to avoid the impingement with the lateral cortex, for example. So the point here is that we sometimes go into unexplored territories. So the idea is to really identify these cases preoperatively, like you showed on your paper. There's the extreme variation and the patient that are outside of the classic curve, and we have to identify and we have to be ready and define probably new norms or new technique for this patient as well.
Mojieb?
No, a fantastic concept. I think a lot of things have been made clear by all the speakers. And I think, the traditional, the way we were brought up by doing the mechanical alignment now has been kind of, there's more new horizon ever since Stephen Howell brought about this new concept of kinematic alignment. So thank you very much, every one of you. Fantastic webinar. I enjoyed every single talk from all of you guys. And this is for our audience who are watching us worldwide. Please just scan this QR code to fill up an evaluation for our webinar. We do have another webinar coming on the 7th of June. That is from the sports medicine group, talking about painful knee joint. And another one from the deformity group. And finally, to everybody watching us worldwide, we do welcome you to attend our 44th World Congress in Belgrade from 25 to 27th of September. So since we have no more questions from our audience, I'd like to thank each and every one of you. And we look forward to see you soon in one of the meetings worldwide. Particularly those who woke up early on, David and Sebastien Parratte. I know it's 6 or 7 in the morning. Thank you very much for your time. And
Thank you.
Thanks everyone.
Thank you, guys. Pleasure.
Thank you. Bye-bye.
Bye.
Bye-bye.
Bye-bye.
Bye.
Bye-bye.